My name is Catherine Lontock, and I am the Director of Science and Policy Communications at IDF. I'm going to be your moderator today. In just a minute, we're going to have Dr. Blachit, and I apologize if I'm not saying this with the correct accent, Davila Saldana will be presenting on emerging immunotherapies. We have about 45 minutes allotted for this session, and we are going to be keeping things on time. So if time permits, we'll get to questions at the end. Couple disclaimers, which you've probably heard at every presentation at this point. Please note that the information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or another qualified health provider with questions concerning a medical condition. The Immune Deficiency Foundation education events offer a wide array of educational presentations, including presentations developed by healthcare and life management professionals invited to serve as presenters. The views and opinions expressed by guest speakers do not necessarily reflect the views and opinions of the Foundation. With that, I'm going to briefly introduce our speaker today. You can find his full bio in the conference app. Dr. Blachit Davila Saldana is an associate professor at George Washington University and an attending in the Division of Blood and Marrow Transplantation at Children's National Hospital in Washington, D.C. His research interests are in primary immunodeficiencies and reduced intensity transplantation. Currently, he leads the Immunometabolomic Transplant Program of the division, as well as the Combined Immunodeficiency Transplant Clinic. Welcome and thank you for joining us.
Thank you very much for the introduction. Good morning, everybody. Correct name. Thank you. Like she said, I'm Blachit Davila. I do bone marrow transplants in Children's National, and I'm here to talk to you about some of the immunotherapies that we are doing in our laboratory. Here are some of my disclosures. The top two have nothing to do with what we're talking about today, but I do want to point out that the biospecific T cells, as well as the T cell depletion methods we're going to be discussing, are not quite yet approved by the FDA. So again, as I mentioned, I am a bone marrow transplanter. So just so that we're on the same page, when we're talking about a stem cell transplant, we're talking about a process that we use to restore bone marrow function. So here to the right, I'm showing you a blood stem cell, and you can see that this stem cell is what gives rise to both lymphoid and myeloid lineages, which end up making all of these cells in your blood. So theoretically speaking, when we do a stem cell transplant, we can provide healthy stem cells that can create all of these new marrow cells. So any disease process that is specific to one of these cells is theoretically something that we could treat with transplant. The transplant process is quite complex and long, so I'm going to try to simplify it for you as best I can. It starts with a donor search, trying to figure out what's going to be the best person that will give us cells for our patients, and then we do what we call the preparative regimen, which helps the patient receive those new cells. And once we give those new cells, that's what we actually call the stem cell transplant, and that is followed by recovery and then a very prolonged monitoring period with us in clinic. Let's break it down a little bit. So in terms of finding a donor, which, like I mentioned, is sort of our first process, it can be the most time-consuming process depending on what we're looking at. We always look at siblings and family first. Now, as you all know, a lot of the conditions that we treat are inherited conditions, so that does mean that it's important to investigate our siblings and our family first if we are to use them as donors. And then at the same time as we're looking at the family, we also look at the unrelated donor registries. The donor registry in the U.S. is known as NMDP, or National Marrow Donor Program. This is their website, bethematch.org. We're always looking for healthy volunteers that are willing to donate marrow. So if you have any friends, any family members that have asked you about that, they can go to this website and register. They will send them kits through their mail, and it's very easy to register. These are shared registries, so it means that we share our possible donors with other countries along the world, and that we can also get donors from other countries in the world if need be. And then lastly, we can also look at cord registries. A question that we get all the time is if we can use the cords that are privately banked, and the answer is no. We use cords that are open registries for anybody to open. So these are cords that are being donated and not privately banked. And then when we look at all of these donors, what we're actually comparing to the patient is the HLA protein. So that's called HLA typing. That's something you may have heard. We do that with either blood or a cheek swab. And the HLA proteins are really what your immune system, what your cells use to talk to each other. And that's why they're important, because we want cells that are able to talk from donor to patient as best as we can. So when we're talking about a good match, that's what we mean, that those HLA proteins are very similar to each other. Once we have the donor, then we proceed to the hospital admission. And this is, again, a very simplified version of how that looks like. Once the patient gets admitted, they would receive the PrEP or preparatory regimen, which we usually describe as minus days. So those are the days that are prior to day 0, which is the actual transplant day or the day you're getting your cells. So if you hear us talk about day minus 10, that just means 10 days prior to you getting your stem cells. And then after day 0, we start counting in positive days, and those are the recovery days until patients are able to leave the hospital. The PrEP or preparatory regimen is a mixture of chemo, different medications, and or radiation. And this has 2 main focuses. The first part is we need to get rid of the old blood production, so we need to empty out that marrow so that we can make space for the new stem cells to come in. And then the second part that we do is we need to get rid of the patient's immune system, because if I were to just give them blood that's somebody else's, their immune system would typically recognize that that's different, and it's going to attack it, and it's going to reject it. So we want to prevent that by using these medications. Now, an important caveat is that this may not be needed in all cases. There's certainly immune deficiencies where the body's ability to reject is very, very low, particularly severe combined immunodeficiency. So, if your doctor tells you you don't need that, that's not necessarily wrong. It just depends on what we are dealing with. And then we do the transplant, which again will be best match donor depending on what we have. We can get these stem cells from many, many different places: bone marrow, peripheral blood, cord blood. And even though we call it a transplant and it sounds like a surgical procedure, for the patient it is very similar to a blood transfusion. It comes in a bag and it just goes through the IV. And those cells actually know how to get to the marrow and do it all on their own. Now, both the PrEP, the transplant, and then the recovery is all done in the hospital. So this is a very prolonged hospital stay, typically about 4 to 8 weeks, depending on what type of transplant we're talking about. Particularly the next 2 weeks after the transplant are very delicate weeks, if you will, because the preparatory regimen is going to get rid of the patient's cells. And then those new cells take a little bit of time until they go to the marrow and divide and repopulate that marrow, and then we start seeing them out in the blood. So that typically takes about 2 to 3 weeks. So that means we're talking about at least a couple weeks where there's not going to be a functioning bone marrow within that patient. And so that's why you may have heard that bone marrow transplant units are very controlled, very tight. There's limited freedom to the patient because it's a very protected environment to try to prevent infections from getting in. And through that low counts, we're going to treat the patients with transfusions because they're not making blood or platelets, but also they don't have white cells, so they're very high risk for infection. And then once those new white cells come in, we have to monitor very closely to make sure that the patient and the new cells are getting along okay. So that's sort of the big caveat, and this little diagram shows you that. So the patient gets admitted, we will give him the prep that will empty out the marrow so that we can get rid of the cells that prevent rejection and also get rid of the blood-producing system. And then we'll do the transplant. Those cells will come in, and then we'll repopulate with new cells that are now from the donor and not from the patient. Okay, so now on to what we'll be talking about. This little diagram tells you a good idea of what we worry about in terms of the infections and the cells that we're going to be giving the patient. So the first 2 weeks after the transplant we talked about is where you really have no counts. And so most patients here are worried about bacterial infections because you don't have neutrophils, which are the main cells that control those types of infections. Now, about 2 to 3 weeks post-transplant, like we mentioned, those neutrophils come in. So that risk decreases significantly to the point that we start talking and thinking about getting the patients out of transplant. But as you see here, the T cells, particularly CD4 T cells, take a much longer time to come back. And that can vary a lot depending on the type of transplant, but it can be anywhere from 6 months to over a year. And that means that infections that are controlled by T cells, particularly viruses, are a really big concern during this period. Oh, sorry, I just realized you're not seeing my pointer. So you see here CMV, adeno, EBV, those are the main infections, the main viral infections that we treat post-transplant. And then we have another possible complication that can happen with transplant, which is graft versus host disease, as you see below. And if we have graft versus host disease, that can actually prolong immunosuppression and prolong the risk for these infections to happen even more. So needless to say, infection and graft versus host disease are the two main issues we worry about post-transplant. And that's what I'll be talking about you today. So what is GVHD? GVHD is when these new cells that we just gave recognize that the patient is different and attack the patient. It's just, a sign of what the immune system is normally supposed to do, right? It's supposed to recognize things that are different and attack them. So the most common target organs are skin, liver, and gut, as you see here. And preventing is much better than treating it. So we try to prevent it as best we can with drugs that cause immunosuppression, as you see here on the right side. Also, as you may imagine, donor matching is a particular component of why we may be at higher risk of GVHD or not. So immunosuppression prevents these new cells from working 100%, and we give that for at least 3 to 6 months or more if there's any issues, until those new cells get along with the patient, and we can eventually remove that. So it's not something we do prolonged. Another thing that we can do is T cell depletion, which is actually removing the T cells from the graft before we give it to the patient. And so we are removing the cells that cause the attack, but of course we're also removing the cells that prevent infection. So infection can be a risk when we do this. In terms of new GVHD treatments, this is actually the first FDA-approved drug for GVHD prevention in decades, and this has just happened in the last decade. This is called abatacept. So in the diagram to the right, I'm showing you a T cell speaking to a dendritic cell, and you see that they speak to this T cell receptor that you see on the left, but there's usually a co-stimulation that needs to happen so that this T cell becomes active. So what abatacept does is it blocks that co-stimulation from happening. And if you have T cell stimulation but no co-stimulation, that T cell doesn't activate. So you're essentially inducing that T cell to stop recognizing that process as different, and it eventually stops doing that, which is what we call anergy. So this is a new method of GVHD prevention that we are now using when we have to use transplants that aren't as fully matched as we want. And then the biggest thing really that has changed in the last decade and that has revolutionized a lot of what we do is haploidentical or half-matched donors. Historically speaking, this was something that was very challenging to do because if the cells are half-matched, they are very likely to be recognized as different. So historically speaking, these transplants had a very high rate of rejection, and then when they did do okay, they had a high rate of graft-versus-host disease. And so there's now two different ways in which we can do haploidentical transplant. Again, both of them have come out in the last decade and have dramatically changed the success of how we do this haplotransplant. And that's very important because it dramatically increases the chances that patients can have donors. So here to your left is post-transplant cyclophosphamide, which we call PT-Cy for short. And what that does is patients get high doses of cyclophosphamide 3 to 4 days after they get the stem cells. So cyclophosphamide is very specific at killing cells that are dividing and proliferate very rapidly. So what we're doing is we wait 3 to 4 days for those cells to recognize the body as different. They start replicating, and then the cytoxin kills them off. So that is how that works. And it does require immunosuppression be continued after we do the cytoxin. So these patients are going to be on immunosuppression for several months post-transplant. But it is a very cheap drug that is very readily available. So that means this is something that can be expanded to many, many places and many countries that have limited resources, including a lot of my friends in Latin America and other countries in the world. Here in the United States, we also have the chance of doing alpha-beta T-cell depletion. So like I mentioned to you before, depletion is when we actually take the T-cells out of the graft before we give it to the patient. And so alpha-beta refers to a receptor in the T-cells, and these alpha-beta positive T-cells are the ones that have the capacity to recognize different things and sort of orchestrate the immune system to do what they do. So when we remove them, we are dramatically decreasing the cells that cause the graft-versus-host disease, but we leave other T cells, which are called the gamma delta T cells, that still protect the patient a little bit from infection, but have much less capacity of doing that graft-versus-host disease. So the benefit of doing something like that is because we're removing the T cells, those patients don't need to be on immunosuppression after, which can be very helpful in cases of immunodeficiencies where you're coming to transplant with a lot of infections. Now, as you may imagine, however, you have to get this product in the lab, and you need a very specialized machine that can get these receptors out, and a very specialized system of people that know how to do that. So requires a significant investment, is very expensive up front, and that's why it's not as readily available. Both of these methods have proven to be successful in different transplant regimens and different immunodeficiencies. We don't have great ways of comparing it just yet. So I would say both of these can be successful depending on what we are transplanting and what we are treating, but definitely something to discuss with your doctor. Now on to infections, which is most of what I do. I'm going to start with a little case. This is one of my patients that we transplanted very recently. He's a 12-month-old that had severe combined immunodeficiency. He was transplanted initially with a very low dose transplant, so an antibody conditioning only transplant with a haploidentical, so very mismatched related donor. And he unfortunately rejected his graft. So he had a second transplant at 12 months of age where we did that alpha-beta depletion that I was telling you about. Unfortunately, the patient developed CMV at around 8 or 9 months of age. So we tried to treat the patient with valganciclovir, but again, this being a patient with severe combined immunodeficiency, it was very hard to control, and it got much worse after the second transplant, and it required multiple antivirals. This is a very big deal in transplant because we know that infections worsen the outcome of patients with transplant. So I'm showing you data here from 2014 from a nice cohort of patients with SCID that were transplanted here in the U.S. And you can see that patients that were treated very early in life or that were treated a little bit later but had no infection did much better than patients that had infections, even in those infections were resolved by the time we went to transplant. Looking at these infections, over half of them are respiratory viruses or DNA viruses. So the viruses that we worry the most about, as I showed you earlier before in the slide. Now, we now have newborn screening for severe combined immunodeficiency, so thankfully that has changed a lot of what we do, but this is data from the Primary Immune Disease Treatment Consortium, and I'm showing you that even in the current era of newborn screening, we still get patients that get infected, and it's still a big deal. Patients that get infected are still at a higher risk of death as compared to patients that are not. So trying to prevent and or treat these infections is pivotal to make sure that our patients do as best as they can. And so this is what we've been working at the most in Children's National. We are trying to make virus-specific T cells that we can give our patients prior to them developing their own T cells so that these T cells can get rid of these infections and provide a window of giving them essentially passive T cells until they can make their own. Now, we can generate these T cells in a lot of different ways. The first method is actually direct cell selection. So we can go to the donor and use either multimodal sorting or detect specific markers in the cells that we know are markers associated with the cells that attack these viruses. And then we can select them and have virus-specific T cells that then we can give our patient. But the work that we've been doing at Children's National is actually culturing the cells for the donor, and then we stimulate them with whatever our target of interest is. So say it's EBV, we have proteins that are specific to EBV, and we culture the T cells in those proteins, and then we have cells that are specific to those antigens that we are culturing them about. Now, when we have donors with detectable memory cells, we can actually just get them immediately from the blood and expand that very quickly, and that is very quick. That takes about a week or two. But if we're not detecting them, then we have to do multiple simulations, and that takes 4 to 6 weeks. The other big issue with this is because we're depending on the donor, then we need that donor to be immune to whatever infection we're dealing with, which can be an issue if our donor is not immune. These cells are very safe. So here I'm showing you data from the Baylor group and then from one of my colleagues, Dr. Cruz. And we have almost 400 T-cell infusions in 180 patients over a 10-year period. We really didn't see any high-grade reactions. Here you see the most common minor reactions that we see. Nausea and fever were the most common, but this only happened in around 5% of infusions. Because we're dealing with T cells, we always worry that this might cause graft-versus-host disease, but it was actually very uncommon. As you see here, less than 5%, around 2% of patients develop GVHD. And then there's always a worry about cytokine release syndrome, which is something that was seen in the patients that get the CAR T therapy, the cancer therapy. But this is also very rare in our patients. As you see here, we had about 2 cases. And these were also always in the case of very severe disseminated infections. So we're talking about patients that have millions of viruses in their blood or like significant organ damage from this infection. We also know that they're very efficacious, so we have dozens of phase 1 or phase 2 studies that we've done internationally, and over 1,000 patients have been treated all around the world with these cells. And response rates are anywhere from 70 to 95%, so it can be very useful adjunctive therapy for our patients. I'm showing you here an example of a very dramatic response. So this is a patient that had PTLD, or post-transplant lymphoproliferative disorder. This is a condition that is related to the Epstein-Barr virus, or EBV. And so we gave this patient EBV-specific T cells after their transplant. And so the diagram on your left, all that white you see is the PTLD in the brain of the patient. And 2 months later, you can see that it was fully cleared. So this was a patient that was in the ICU with terrible mental status and made a complete neurological recovery after these cells. So this is the protocol that we open at Children's National. It's called the NATS trial for a team in DC that I will not name at the moment. And needless to say, our GMP director is a big fan. And so we did cells, and we can actually teach this cell to target several things at once. So these cells were targeting all of these 6 different viruses. And so far, we treated 17 patients. On the top, I'm showing you the responses. So everything green is a complete response, and blue is a partial response. So overall, over 80% of the patients that we treated had a response. And in CMB, you can see that was very good. So 5 of the 6 CMB patients responded fully. And then we also follow their blood, and so you can actually detect T cells that are proliferating and that are specific against the viruses in our study. So to the bottom, I'm showing you a patient who received 2 BST infusions for CMB and for BK virus. Both of these infections cleared, and then what you see in blue is the amount of cells that are specific to CMB. So you can see a quite nice response after our BST infusions, and then a smaller response in the green line, which is the BK virus. So this was going back to that patient that I showed you at the beginning. This was my patient with CMB and SCID. He had CMB in the millions, as you can see here. We gave him the cells, and you can see this dramatic decrease. Now he had significant symptoms around this time, which is a little bit of that CRS I mentioned to you can happen when you do the cells in very high level of cells. So he got a dose of tocilizumab. It resolved all his symptoms, and then you see that his CMB went to 0 and never came back. He made a full recovery. Now, these cells do have their limitations. Like I mentioned to you, we need an available donor, and we need a donor that is positive to whatever infection we're talking about. It also takes a lot of time to make these cells. So we were also interested in seeing if we can do a third-party trial. So that means rather than getting the cells from the donor, having cells from random donors that we have just stored in the bank that may not be fully matched to the patient, but that have a partial match to the patient. And that way we can just have these cells readily available and try to give them to patients as far as we can. So we did this study through the Pediatric Transplant and Cellular Therapy Group in the US, and we were the center that provided all the cells. And there were 2 arms, either for patients that had viruses following transplant or for patients that had primary immunodeficiencies and had infections before transplant. So these are those results. We did 69 total infusions in 51 patients. One of the questions we have was, is our bank sufficient to find partial matches for everybody? And it was actually quite successful. We had 77 queries, and 97% of those we found a match for. We treated 47 patients in the post-transplant arm and only 4 pre-transplant. And here you see the diseases. So it's kind of evenly matched between malignancy patients and patients with immunodeficiencies, a lot of different immunodeficiencies. Adenovirus was the most common thing we were asked for, which makes sense because we don't have great therapies for that. But we had a lot of CMV and then not as much EBV. And then this is the matching that we did. So this is matching out of 6. So you can see that the vast majority of them were mostly partially matched. Most of them about 3 to 4 out of the 6 matches. we had 46 patients that were evaluable after a month, and our response rate was 65%, so about 2 in 3 responses. And here I'm dividing them between diseases. It took about 28 days was the median time for the cells to actually do their job, so it does take a little bit. And here I'm showing you, again, another example of a patient's viral load. This was anno, and you can see it was very high to about 300,000 copies and then dramatically reduced after a month after the cells. And then another good thing is because these patients had T cells and were resolving their infections, they were able to stop a lot of their antivirals. This is the survival for the cohort, so around 2/3 of them were alive up to 3 years post-transplant, with 10 deaths due to progressive viral disease. And so you can see this number is very similar to the responses that I showed you before, because unfortunately patients that didn't respond were had a much higher likelihood of death. There was no de novo GVHD. We did have one patient with CRS, which was my patient that I showed you, and then we did have one patient with a secondary graft rejection. We tried to look a little bit more about the differences in survival, and so here in the right, I'm showing you the difference in survival by acuity. So the red line represents patients with high acuity, so patients that were already in the ICU, already intubated, already with renal failure at the time we gave the infusion. And you can see that, unfortunately, those were the ones that didn't do as well. So the blue line has survival over 80% as compared to that. And that's likely because, as I showed you, it does take a while for them to work, typically about 3 to 4 weeks. So the earlier we can do this, the better. And then we also did an analysis to try to see what other things could tell us if these cells are working or not. So this is not very surprising, but if you had GVHD and you were in immunosuppressants like steroids or ATG, those patients were less likely to respond. Another one that was a little bit surprising to us is patients that were diagnosed with TMA or thrombotic microangiopathy, which is a post-transplant complication, and were being treated with eculizumab, a drug that is very commonly used to treat the TMA, didn't respond as well. Now, that is something new that we hadn't seen before, and as I showed you, many other groups have done these studies and nobody else had seen this correlation. So I can't tell you for sure that this is definite as opposed to everything else, but certainly something that needs a little more evaluation. Now, I showed you that the third-party cells do seem to work, but I think we still need to work on improving efficacy. And so I think we need to improve our algorithm so that we can hopefully make the cells work a little bit faster and help those patients that were a little bit sicker, as I showed you. The other thing is viruses can mutate, as we see with flu or COVID, for example. And so we may need more studies to figure out different ways where we can treat them where they mutate. And then lastly, as I showed you, GVHD in particular is a big issue for the cells to work, and unfortunately a lot of patients with GVHD are the ones that have the infection. So we are working on trying to edit the cells to see if we can make them resistant to some of the things that we do for graft-versus-host disease. And then of course improving safety, particularly for those patients that I showed you with very high risk. It takes a village to make this cell, so Dr. Ballard is the main director, and then Dr. Keller is the main one that does these cells in the lab. But I'd like to thank everybody as well as all these other collaborators that participated in that study that I showed you. But I hope I've showed you that we are finding new ways of treating both the GVHD and the infections, which ultimately should result in better transplants for all our patients. So thank you very much, and with that, I'm happy to answer any questions for you.
All right, so before we get to questions, I just wanted to highlight some resources that you've probably seen at every talk. But just in case you haven't, Ask IDF is our sort of online answering service. We will take any question related to PI and either get you an answer, a resource, or point it in the right direction. We also have these great Get Connected groups, they all meet online. Some of them are geographically based, so even though you are meeting online, there are people in your area, and some of them are diagnosis based, so definitely check those out. And please, please, please complete your session survey within the app. We need your feedback to know what went well and what didn't. So thank you very much. I'm gonna hightail it to the back to get my, my microphone because my colleague is running another session right now, and then we will take questions. All right. Is this on? Yes. Okay. Sorry, it's hard to tell. Before we take questions, I do want to just say a couple of ground rules. Please keep the questions relevant. Please do not share personal health information. And please do not mention specific products, providers, or institutions. All right.
Oh, sure. Thank you. Hi, thank you for that informative talk. I had a question. You said that one of your interests was reduced intensity conditioning. Can you just talk a little bit about that and impacts on GVHD or infection rates post-transplant?
Yeah, sure. That is a great question. I will say it does vary a lot depending on what disease we're talking about. So definitely something worth discussing with your doc, or talk to me later, and I'll happy to give you specifics. But in general, the chemo drugs that we use, like I mentioned, have a dual purpose of like getting rid of the immune system cells, but also opening up the marrow. So the more intense you go with those drugs, the more likely it is that you're going to eliminate every cell from the patient, and then all of them are going to be the donors. But the higher you go with the drugs, the more toxicity you can do. So when we talk about a reduced intensity transplant, we're talking about trying to either use drugs that are less potent or use less doses of the drug so that the toxicity becomes less. And so that does mean that the transplant becomes a little less toxic and a little bit more tolerable. It does mean there's a higher risk that you may not be able to eliminate all of the patient's cells, and some of them might stick around, and you might end up with what we call mixed chimerism, meaning both the donor and the patient's cells at the same time. Now, sometimes that's okay, right? There's a lot of diseases where you can have both cells and you will be okay. There are some times where that's not okay, cancer being the obvious example, but sometime in the realm of primary immunodeficiencies, that is still something to consider. So that's why I mean that it's very specific to the patient, but I would say particularly for our patients that already come in with a lot of infections and have organs that aren't working 100%, a few of my other research areas are trying to cut down on chemotherapeutic agents that will harm that organ even more so that we can still do the transplant safely.
Okay, kind of a two-part question, but it almost piggybacks with this, that when there are comorbidities, you know, with the PI and maybe autoimmune inflammatory diseases, and you're not really severe where you're having severe organ problems, it seems like it's hard for people who are just kind of, we're hanging on, we're not severe, but to me it makes more sense. I mean, it's definitely help the people who are severe by all means, but at what point can they help the people that are kind of mediocre so they don't get severe? And if their liver and kidneys and everything are functioning good, wouldn't they be better, you know, might be able to survive and recover quicker?
Yeah. I hear you. It's a great question. It's something we discuss all the time amongst us. I think there are definitely diseases where we know if we don't do something, things are going to end up really badly, right? Severe combined immunodeficiency is a perfect example where we know there's an over 90% chance of death within the first 2 years if we don't do anything. So I think everybody is on the same page, like, yes, this is something we need to do. Now, there's a lot of immune diseases where we don't quite know what's going to happen, you know? So patients do very well. Some patients get very sick. And then those are the ones that are a little bit harder to tell you point blank, we should do this for everybody, particularly because unfortunately all of these diseases are very rare, so it's very hard to get a lot of data longitudinally to see how everybody does. Typically, what we do is we have a combined clinic, so with our immunologist and then me, the transplanter, and we will see everybody that has a possible life-threatening immunodeficiency. It doesn't mean that everybody goes to transplant, right? It just means that they meet me, we can do the HLA typing, we can see what donor options are there, and then patients, for those type of disorders, usually patients that are doing very well, I will just touch base with them every now and then, but then that's it. And then patients that start getting into trouble, then we start having a little bit more conversations, because I agree with you. Unfortunately, when we do have organ damage, that dramatically complicates how we do the transplant. So it has to be a balance of I will try to leave you alone if you're not having any issues, but then once you start having issues, we should start having conversations about what we think is safe from that standpoint. And I'm sorry, that's very vague, but unfortunately it does vary a lot depending on what disease we're talking about, and there's also no great sort of like defined guideline for most of them. So yeah, ultimately ends up being a big patient-doc conversation about what we think is the best path for both of us.
Work with our own physicians in our own clinics and hospitals, determine if and when.
Right, exactly. I would say work with the physicians, and I would also say the research that she just pointed out at the IDF is great. So, there's not a lot of us that do transplant for immunodeficiencies, and we're all very happy to chat about possible secondary cases or how we would manage things. So yeah, definitely reach out through them, and we can definitely discuss things more in detail.
I have a question about in the use of the immunosuppressive drugs or chemotherapy drugs post-transplant, do you ever see cases where the donor, whether they were or weren't tested for genetic abnormalities, the donor bone marrow then becomes damaged by the chemotherapy drugs given post-transplant, as somebody who had bone marrow damage from chemotherapy drugs for a brain inflammation lupus, knowing that can happen in up to 4% of people? Are the donors for bone marrow tested for those sensitivities to those types of medications?
Let me see if I'm understanding you correctly. You're asking about if the donor not the donor himself, but the donor cells can be affected after the transplant inside the patient. Is that right?
Right. Correct. So that you don't then go, oh, well, those drugs actually damaged this new bone marrow, and now you're in a similar condition.
Got it. Yeah. Well, I think thankfully we're getting to the era where we can define a lot of the things that we are transplanting. So I would tell you, the vast majority of patients that come to transplant with me, we know what the genetic defect is, and then we always test the family or the donor for that particular thing to make sure that that's working okay. Now, there are certainly patients where we're not entirely sure what's going on, and they may still need a transplant. Those, I would say, are getting rarer and rarer as we get better with our genetics, but it certainly still happens. And then I think those are the cases where we can sometimes run into issues like what you're describing. So, for example, there are a few diseases that have only been described in the last 4 to 5 years, and so we had done a transplant before where we had tested and our donor was okay, but then of course once we figure out this new gene, it ended up that our donor had the same condition. So that can certainly happen. I think it's exceedingly rare. Specific to what you're describing though, there is a new test that can test what we call radiosensitivity, or sort of the sensitivity of the cells to chemotherapy and other agents. And so when I have patients where I'm not exactly sure what's happening, I do send that test, and that is usually very helpful in terms of making me feel safer about the fact that I can give chemotherapy. This is, oh my God, that's terrible. I'm blanking out on her name. It's a test out in Columbus by a brilliant immunologist that used to be part of the IDF, and her name will come to me in a few minutes. I'm sorry.
All right. Unfortunately, we have run out of time. Thank you again to our speaker. If you have remaining questions, Ask IDF is your place to go.